So the next and last topic in our series of pediatric retinal lectures is going to be ocular findings in children with abusive head trauma. I know you already had a quick summary from Dr. Chung on Blackboard on abusive head trauma and retinal findings in it. So this lecture part will be essentially looking at epidemiology, mechanisms, and types of abusive head trauma. We'll briefly discuss physical abuse in the children, diagnostic evaluation, and management review. Then we'll further go into the details of the main topic here, which is retinal hemorrhages after abusive head trauma, anatomy, pathogenesis of it, and then we'll go beyond retinal hemorrhages and we'll talk about other ocular findings associated with abusive head trauma and their implications. Of course, like anything else, there are differential diagnoses that you have to look into the consideration, and we'll cover that briefly. And finally, without going into much details, I'll cover the summary or a quick review on the management of ocular findings of AHT. So abusive head trauma, how frequent is it? Unfortunately, under 2 years of age, 17 out of 100,000 person year is what is the incidence of AHT. It's more so common in kids who are under 1 year of age versus those who are in 2 years of age. The ratio is around 30 versus 4 per 100,000. And abusive head trauma is the commonest cause of lethal physical abuse. When it's present, a lot of the time, the findings are non-specific, and unfortunately, 30% of the time, it's misdiagnosed initially. And 66% of the time, we know the person who has done the damage, or we know the perpetrator, and half of the times, these are fathers, stepfathers, and 20% of the time, 12% of the time, it's mother, and unbelievably so, female babysitters can be involved in as high as 17% of the time. But still something noticeable here is parents are major proprietors when it comes to the causative reasons. There were several infant factors which have been epidemiologically studied to be associated. For example, if the child had a perinatal illness, for example, they're premature, the labor was obstructed, or they had prolonged hospitalization after birth, they have increased risk of having AHT. If they have any major birth defects, they are increased risk. If the child have incessant crying, or what is commonly known as colicky babies, they are at increased risk of having AHT. And epidemiologically speaking, male gender has higher association with abusive head trauma. There are some family risk factors. For example, if there's a history of familial dysfunction because of drug abuse, violence, psychiatric illness, they're associated with increased association. If the mother is young and immature, they are associated. If there is family disruption or separation, including even maternal military services, and you can imagine in that case, if the father is the only care provider, they are associated with increased risk of AHT. There has been a history of AHT in the first child and it could not be caught. There's increased risk that other family members will have AHT as well. There are economic factors unfortunately associated with it. From what we know that AHT incidence usually increases when there is economic recession, and since we have had economic recession in 2007, there is some increase in AHT incidence. So how does abusive head trauma actually happen? There are certain things which are unique to the child who's under 1 year of age that led them to develop this propensity of the injuries. If you look at the coupe-contra-coupe injury mechanism, which you might have heard about when it comes to ocular coupe-contra-coupe injury, but very similar coupe-contra-coupe injury happens in case of infantile head trauma as well. These brains are particularly vulnerable, especially to angular rotations, deceleration movements, and more so if they have these repeated episodes of shaking of the head, they are at higher risk. And if we want to go into the detail, let's look at the skeleton on an adult on the right side compared to that young child skeleton on the left side, and you can see they have a lot more flatter lower surface a lot more bigger head size. And as a result of this flatness of the base of the skull, the brain moves more readily whenever they have deceleration forces. Also, the skull is thin and pliable. So if there is any pressure applied to the skull, those forces are more likely to go across the bones and affect the brain per se. And again, if you look at the size of the head, it's a lot larger, it's heavier, unstable. And if you look at the statistics, brain of a 2-year-old is almost 75% of the adult brain. And you can imagine how the rest of their body is. So that creates this disproportionate head size, disproportionate vulnerability of the head to any acceleration-deceleration injuries. And so also another factor which is attributed to pediatric head trauma, abusive head trauma, is their brains are relatively quote-unquote soft because they have a higher water content. And also, since CNS is not completely myelinated, they don't have auto-regulated blood flow after the injury that can prevent the injury progression per se. So what exactly happened what kind of injuries do you have in AHT? You can have a primary injury, which depending on type of severity of the injury, can have a mechanism from rotational or translational energy, leading to parenchymal injuries and hematomas. You can have a fall, in which essentially there will be translational deceleration associated with the injury. Another way of classifying or other subcategory of type of injury is secondary injury, in which you do not have direct trauma to the brain itself, just as you have in primary injury, in which you have a direct trauma to the brain tissue. Here it is secondary to hypoxic ischemic episodes that happen post-trauma. So if you look at abusive versus non-abusive injuries have 3-to-1 ratio of hypoxic ischemic damage per se. So how does exactly it happen? So the pathogenesis mechanism that is commonly discussed is secondary to the brain trauma, you develop central apnea at the brain stem center or cervical spine injury levels that lead to ischemia, and that ischemia eventually hurts the brain. Also, if you have a primary injury to the brain and subsequently patient goes into a seizure activity, the prolonged seizure activity itself can cause ischemia to the brain tissue. Another mechanism of ischemia include aspiration of fluids into the airway during the time of trauma, and that hypoxia will cause hypoxic damage to the brain. And last and not the least is cerebral blood flow changes, as we covered earlier. Since they have immature brain tissue, they are not prepared to deal with autoregulation, as you will see in the adult tissue, and these changes lead to secondary injury. Where exactly the injuries happen, and believe me, when we discuss abusive head trauma, that is the reason I've tried to cover AHT before discussing retinal hemorrhages, because retinal hemorrhages are technically considered part of AHT process itself. You might have heard during your courses, eyes are part of your brain in a way, and that's exactly, retinal hemorrhages are considered the first and foremost finding of AHT. So besides bleeding in the retina, you can have similar bleeding in different layers, intracranial bleeding in different layers, subdural, intraparenchymal, subarachnoid, or epidural. You can have injury to the brain tissue itself or parenchymal injury. You can have spinal and paraspinal injuries, or you can have skull fractures. So these are essentially injuries focusing just on the head trauma part of abusive trauma itself. And of course, if you go beyond head trauma, you can also have skeletal fracture elsewhere, and they will be considered part of AHT as well. So we talked briefly about AHT, its pathophysiology, and briefly discuss the findings. Let's look at the physical abuse and some signs of physical abuse, because as an eye care provider, we are required to report it. Again, the reporting policies and how to report it, whom to report it, goes beyond the scope of this lecture. But I'm essentially trying to focus on the physical abuse part of it. So identification is not only to treat the current conditions, but also it is important to protect the child from subsequent trauma, and also to prevent the next generation from getting the trauma, because we know if you don't catch it early enough, you don't treat it early enough, there's a 50% chance that this child will get further abused. And if you don't catch it and again prevent it, there is 10% chance that the next abuse may lead to mortality of the child. So what are the helpful things to look at? Most of it is common sense, but I still have tried to summarize it. For example, a patient comes here, you see a bruise and you see an injury, and you say to them, hey, how did this injury happen? And the father said, well, or a parent said, or the caretaker said, they just fell from a sofa. And you look at one fall from sofa cannot cause multiple fractures. So that should cause a problem. Or it could not cause serious intra-abdominal injury or severe head trauma. So the history is inconsistent. Or if you ask them about the trauma, their details are vague. They are not able to tell you the exact details. Or if you ask multiple caretakers, you will see different versions of the way the trauma happened. So we have to be really careful. If you see a sign of trauma, you got to ask that caregiver, and you have an opportunity to discuss with the other caregiver. Try to ask them, see if their history kind of makes sense. That will help us point toward if it's abuse present in this case or not. Sometimes you will be surprised. There's an injury and you ask about it, and they say, hey, well, the kids were playing together, and there's a possible that sibling might have caused an injury. Sometimes it can be true. There can be some level of sibling rivalry, but sometimes the amount of violence that you look at it kind of make you think like, well, is it a cover story? If it's a sibling rivalry causing an injury, is the child having adequate supervision or not? Is there violence at home that the sibling is getting exposed to and he is expressing that on the child? If, for example, they don't offer any history and they say, oh, I don't know how that happened, I have no idea how that happens, and suddenly there's a leg fracture, the leg is broken, that is consistent with some level of abuse likely. Also, if you see certain fractures, certain changes, and in a child, and they say, hey, this baby went into hot tub and burned themselves, and you're looking at the baby, he is not able to even sit up without a support or with the support, or he's not at the stage in which he can crawl. It does not make sense that that child will go ahead and crawl into a hot water tub. So it's most likely an abuse. And other things can be in plausible history. They have an obvious lesion, and you look at the lesion, and there's a fracture, and there's a bruise, and they say, hey, it could be a roach bite, but the roach bite is not going to cause a bruise of a fracture. So these things kind of doesn't make sense. So as I said, these are common historical factors. Again, a lot of them are common sense, but help you suspect child abuse. Other could be examination findings. You did an exam and you're seeing these findings which are not consistent with the history. The way the trauma history is given doesn't collaborate with the findings you have, or you have multiple fractures in various stages of healing that doesn't go along. If you have different kind of bruises, burns, fractures, different kind of injuries in the different stage of healing, that point toward abuse as well. There are some histories which are increasingly associated with abuse. For example, bruises in the children who can't cruise. There's no way for them to run into the things and get bruises because they can't even cruise yet, as we discussed earlier. Bruises on the trunk, ear, and neck. These are the typical susceptible areas in which you can see the injuries coming. If there are long bone fractures in the kids who do not walk, again, similar logic. Rib fractures in infants younger than 1 year of age. That rib fracture is highly indicative of abuse. Similarly, if they have a hollow viscous injury in a child younger than 4 years of age, there is no reason for a child to have that kind of trauma. It's suggestive of abuse. Subretinal hematoma in infants younger than 1 year old are all suggestive of abuse. So I'm going to share the slide deck, and you'll be able to see through it. This is just a quick summary. I can gain a little bit beyond the scope of this course and lecture. If you see a child with a trauma, what are the different things to look at? This is again your A, B, C, D, E resuscitation, and goes beyond how to manage and how to go about managing it. Again, in our case, and as an optometrist, a lot of the time, you have to provide basic life support, try to call 911, and try to see if you can keep a child stable until the care is available. Also, go further down and discuss about how to go about examining a child. Again, as an eye care provider, it's a little bit beyond our scope to look at it, and we're going to cover the eye examination, all those details later on. These are diagnostic tests, some of them for the fractures, bruises, injuries, and what are the findings which are usually associated with abuse. And I got a summary here for you. And again, as we discussed earlier, I'm not going to go into the details of how to manage it. But again, these tests have to be ordered carefully because these are younger kids. You don't want to expose them to too much of radiation. Again, carefully, depending on their age, clinical findings, do the testing accordingly. Generalized testing usually is not the smartest way of going about it. Do CAT scan if required. Again, CAT scan has a lot more radiation exposure. When possible, do MRI when applicable. Sometimes it is required to hospitalize these patients, not only for the management of the illnesses, but also sometimes to involve child welfare services and for the safety of the child. For example, you don't want to send the child back to the abusing household or abuser where they can have further injury again. So that was a abusive head trauma and in general abuse injury. And now we're going to focus on retinal hemorrhages of abusive head trauma, starting off with anatomy and pathophysiology. Again, you already know this is a structural anatomy. What I'm trying to look at is the different areas, different vascular plexuses which are present in the retina and the location of different plexuses. Again, retinal vessels are contained in the neural portion of the retina. The large vessels cross through the nerve fiber and ganglion cell layer. Small vessels, stay between NFL and inner nuclear layer. And there are 3 layers of retinal capillaries. There are those between NFL ganglion cell layer, those in inner nuclear layer, and a radial peripapillary capillaries around the nerve. So pathogenesis is very similar to the other trauma. Most of the time it is from acceleration-deceleration injuries. Sometimes they can be direct optic nerve injury. Sometimes they can be increased intracranial pressure, causing pressure on the optic nerve, causing the problem. Intracranial bleeding can have its impact on the visual pathway. And there are different theories looking at increased intrathoracic pressure leading to ocular injuries as well. So this is a case of University of Iowa 2004 acceleration-deceleration injury causing a trauma in which orbit is hemorrhaged and an orbital hemorrhage because of abusive head trauma. So the orbit is full of blood and is causing pressure. It will cause indirect damage to the optic nerve. The shearing force of the trauma itself from acceleration-deceleration will cause vitreoretinal interface to have the shearing force transmitted it to, and that can cause a problem. We already talked about how direct optic nerve injury can happen as well. So optic nerve, how does that come into the play? So we know that optic nerve is longer compared to the radial length of the orbit itself, and all other intra-op structures are firmly attached except optic nerve has a little bit of longer length, and as a result, when you have shaking of the child, this will make the globe and orbital content to move as the child is shaking. And this nerve is pretty much attached to 2 different spots, one in the orbital bone, the second part, orbital occipital canal, and second part is by the retina. And as a result of this movement, you can have translational and rotational injuries, which can affect the optic nerve itself. If you look at the vitreoretinal shearing forces, and if you look back at the chapter in which we covered vitro-macular interface anomalies, VMT, PVD, there are tight attachments in the different areas, and from our PVD lecture, if you can remember, these areas of tight attachment are usually susceptible when PVD happens, and these are the areas which usually bleed. Now imagine similar tight attachment throughout the retina, and with shaking trauma or abuse, all these interface areas are getting shearing force transmitting to them, and as a result, these vitreoretinal interface areas will get direct damage, and these forces will cause bleeding in the areas, usually involving macula, retinal blood vessels, peripheral retina, leading to hemorrhages, which can confine to vitreous base. And in some cases, the trauma itself can cause the layers of retina to detach, or in other words, the areas of tight vitreomacular traction will cause schisis of the macula to happen. Also, secondary to these shearing forces, you can have a disruption of autonomic supply leading to retinal hemorrhages through the disruption of vascular integrity and autoregulation processes. So these are the pictures, and you can see on the picture on the left side there is an orbital hemorrhage, and this orbital hemorrhage can be seen on the scan here. And then if you look in the right side image, there is actually sphenoid fracture, and you can see both different kind of injuries translating themselves and causing optic nerve injury. So again, the reason these patients develop atrophy could be from direct optic nerve hemorrhage or direct optic nerve trauma itself, or as it is explained here, you can also have optic sheath hemorrhage that can itself cause trauma to the optic nerve as well. Another theory for pathogenesis is increased intracranial pressure. That's secondary to different kind of hemorrhages, cranial hemorrhages that we talked about earlier in the lecture, or because of cerebral edema, there is increased intracranial pressure. That increased intracranial pressure will cause retinal vasculature to give up and will cause bleeding. Also, there are other theories, including theories looking at paroxysmal cough coming with increased intracranial pressure leading to retinal hemorrhages. And this is an example of similar hemorrhage around the optic nerve head, which is likely associated from it. And you can see that scans which actually look at the blood collection in the scan itself. We already talk about Thurston syndrome, in which we know retinal vitreous hemorrhage is associated with subarachnoid hemorrhage. It merely refers to association, and again, we do not exactly know how the specific etiology happens, but we know intracranial hemorrhages can translate, Thurston syndrome can translate itself as retinal hemorrhages, and this is one of the pathogenesis theories, how we get retinal hemorrhages in abusive head trauma. Another theory is Purcell syndrome. So if you remember, Purcell syndrome is again from severe abusive intrathoracic injuries, and those intrathoracic injuries are associated with retinal hemorrhages. So this is another theory of why patients will develop retinal hemorrhages secondary to post-traumatic. Again, there are different mechanisms proposed, and there are different evidence that support it, but again, these are all hypotheses. So this was a detailed description of how in abusive head trauma you get retinal hemorrhages, and we kind of talked about direct injury to the blood vessels for vitreoretinal shearing forces. We talk about Thurston syndrome, Purcell syndrome. We talk about increased intracranial pressure. We discussed how it could be shearing forces to the shearing damage to the optic nerve with associated damage and causing hemorrhages. And these are the different theories there to explain why these patients develop hemorrhages. So let's go ahead and look at the ocular findings of abusive head trauma. So if you're doing the examination, the commonest finding you'll probably see early on, these are pediatric patients, difficult to examine. One of the earliest findings you may see is a poorly reactive pupil. Or when you're trying to check for fixation or trying to check their vision, they may have either decreased vision, or they may have a gaze preference for one eye rather than the other, may have a fixation indifference. And further in the exam, you may see periorbital ecchymosis. You may be able to, on your examination, palpate or otherwise see other findings suggestive of orbital fracture. If you have subconjunctival hemorrhage, especially if the child has not been vomiting and coughing, there are not many reasons for subconjunctival severe hemorrhage in the kids that will be suggestive of abuse. If you see hyphema, that is suggestive of trauma most likely. And of course, we talk about retinal hemorrhages from occult intracranial injury can be the presentation of abusive head trauma. Of course, later on, the same abusive head trauma patients will develop other findings, including we talk about optic nerve in length. You can have optic atrophy. Again, if vitreoretinal traction forces are causing premature PVD, contour coupe injuries, you can have second to that retinal holes, retinal detachments, You can have choroidal ruptures. You can have retinal edema following scarring sometimes, are all associated with the patients with their findings. How do you go about examining these patients? Of course, these patients, when you examine them because of sedation and narcotics and painkillers, you'll see a lot of these patients will have pupil reconstriction. And that really comes in the way of doing examination. So it is preferable to dilate these patients, and sometimes you have to do pharmacological dilation. And something important here, I know we covered different kind of retinal imaging techniques early on, including retCam. These are the patients in which you got to have the evidence, because more than likely your retinal findings are going to be one of the few diagnostic findings, and if you do not have photo documentation of it, it becomes really difficult to prove. So it's very important to document these patients, and these benefits of pharmacological dilation usually outweigh the loss of ability to monitor pupil reaction for several hours. And that's what you will see a lot of the time. Intensive care unit docs or pediatrician will be trying to discourage you to do the dilation, and most of the time the benefit that you get not only in diagnosis and management from the examination really has a value that that should be discussed, and you should try to see if they can use alternate resources for their monitoring other than just checking pupils. One way I have seen being done is you look at the pupillary reaction, you decide which pupil you want to dilate, and you keep only dilate one eye and not the other. And that is probably a good question for you. If you want to just look at APD, do we really need to have both pupils available to diagnose APD? If you remember time with me in the clinic, I have asked this question to you. Actually, think about it. Do you need both pupils available to look at APD? And actually the answer is no. You just need to look at one pupil to determine if there's an APD or not, because with the swinging light reflex, you can check the other eye. Also, in case you have only one pupil available, it will be indirect APD assessment, but at least you will be able to make that assessment. We talked about retCam, and we talked about how important it is, and I just covered with all these details in an earlier lecture. It's very important to do the retCam imaging is in these patients in order to diagnose and document the hemorrhages. And this is a little picture I didn't have in my retCam video, but this is how the retCam is held, that's how it is placed, and that's how imaging is done. And these are again few images from retCam. If you pay attention, look at the findings in the bottom left. These are subtle few hemorrhages, dot plot hemorrhages present. On the right side, on the top right, actually there is not the patients of abusive head trauma, but are patients with ROP. So is the patient on the top. And these white marks that you see in the bottom left are laser marks. So these are just images for the retCam understanding. This is a dilation guideline. Again, something you're already familiar with. Something you have to remember is phenylephrine for little babies can be dangerous. You have to be careful when you're using it. And again, I have this guideline here, which you are already familiar with. Pupillary dilation is a topic that must have been covered elsewhere, but that's how you do it. So retinal hemorrhages are seen in 47 to 100%. So that's very interesting, right? So almost all the patients of abusive head trauma can theoretically have retinal hemorrhages. And frequency is approximately 85% in most of the case series. So yes, that is very, very important. That's why our consult, eye care provider, optometry, or ophthalmologist is of significant value in diagnosing these hemorrhages. Sometimes they are not seen, and they are seen on autopsy findings, or then at that time it's kind of too late. But again, you will look at different studies documenting how important it is. They are, once you see those hemorrhages, there are not many reasons in a child to have those hemorrhages. If you see that in your exam, that should really make you suspect something is not right, and should flag in your mind and try to look at the signs of abuse and try to look at other findings that may help you point toward it. How do you describe it? It's important to look at the number of hemorrhages, the pattern of distribution, the type of hemorrhages, And type and severity of hemorrhages have diagnostic and prognostic implications. Also, severity of retinal hemorrhages is also correlated with the severity of intracranial abnormalities, and these are strongly related with the long-term and short-term sequel and survival post-traumatic head trauma, post-abusive head trauma. So these have a lot of value in that. Again, this is a little guide for you to look at how retinal hemorrhages are looked at, diagnosed, again, something which we have covered in our course already, your PPO course in which the retinal examination was discussed must have covered these details as well. So, but you have this available. This is another preretinal hemorrhages in which you can see there is a hemorrhage in the potential space between retina and vitreous. Typically, they're large and they can be obscuring the view of blood vessels. And sometimes when the patient is sitting up, these red cells will settle down and they will create a horizontal line of demarcation as is seen in the diagram on the left side. And this horizontal line of demarcation is created by plasma on the top and the blood in the bottom, and very similar to the findings as you can see here. Similarly, here you have the superficial retinal hemorrhages, small linear flame-shaped red streaks at the fundi, and again, superficial hemorrhage is something you're familiar with. And this patient actually, on the one on the right, had subdural hematoma and cerebral edema, and these images were diagnostic in abusive head trauma. This is another patient with abusive head trauma. In this case, they have subretinal hemorrhage. And you can see there are a slight irregular red spots that sometimes can become dot and blot. Really pay attention, you'll realize they also have deeper hemorrhages, which are flame-shaped in nature, and you can see them. These are some areas of hemorrhages, and there's some retinal edema associated with it. And then, of course, we have this hemorrhage over the macula. So retinal hemorrhages usually are bilateral, although they may be asymmetrical. But having said that, unilateral hemorrhages are also being associated with abusive head trauma. Laterality usually tells you, hey, there may be more brain bleeding on the side with more hemorrhages. It's not always a rule of thumb, but that does point toward it. In majority of the patients, too numerous hemorrhages are sometimes difficult to count, and you can't see how many of them are. 2/3 of them can involve multiple layers. And also in some of these patients, these hemorrhages may appear to have a white center, which is made of fibrin plug or something else. And these white-centered hemorrhages should not be described as rot spots, because doing so will falsely imply that these hemorrhages do not have origin from abusive head trauma, but instead makes it feel like these have from, for example, infection. So very important. I know we use the word rot spot to usually describe the hemorrhages with pale center, but if you see them in a patient like you have here, these hemorrhages with white center inferiorly and inferotemporally, these patients describe them hemorrhages with white center instead of describing them as rot spot. So you can strongly support them associated with abusive head trauma. In the literature, you will see people calling them rot spots as well. That preferable is to call them as we discussed. So these retinal hemorrhages, grading is very subjective. There are several criteria laid out, but one of them is you can classify them as a mild, moderate, severe. Mild means it's intra or preretinal, perivascular, peripapillary hemorrhages. Moderate is when besides these hemorrhages, you have papilledema associated with it, but there's no vitreous hemorrhage. And then the last one, severe, is when the too numerous, there's a macular cyst greater than 2 optic disc diameter in size. That is suggestive of severe. So again, the summary is mild is intraretinal, preretinal, perivascular, peripapillary hemorrhages. Moderate is intraretinal, preretinal, subretinal hemorrhages, along with that papilledema. And severe is when you have associated macular cyst greater than 2 disc diameter in area. What usually happens with these hemorrhages over the time they resolve depends on the hemorrhage size, how long you have it for. Flame hemorrhages usually resolve faster than preretinal hemorrhages. If you have blood in the schisis cavity, that's going to be the slowest to resolve. If you, amongst the intraretinal hemorrhages, if you have vitreous hemorrhage, this will be really, really slow. And subsequently, you will see patient will either develop retinal scarring or optic atrophy associated with them. Because of the marked variability in the resolution time, retinal hemorrhages should not be used to estimate the day of injury. So if you see injuries that just based on the hemorrhages itself, it is not judicious to quantify how long ago the injury happened. Other retinal findings, as we discussed earlier, could be retinal folds, retinal schisis. These are central retinal folds and usually are associated with abusive head trauma. They're pathognomonic. Sometimes crash accidents, motor vehicle accidents are associated with retinal folds as well. But if you don't have history of a severe trauma to some extent, that should be indicative of abusive head trauma. Also, retinal folds suggest there is injury elsewhere, and they are strongly associated with jet and neurological sequelae requiring further testing. So this is a patient actually with traumatic schisis, and you must be surprised why is this following this interesting pattern. Actually, this patient is laying down on the side, so that's why the nerve is superiorly, and these are arcades, and then because of the position they have, the blood has settled down laterally, showing this appearance as we can see. That's also in some patients you will, instead of seeing a characteristic finding of hemorrhage like this, you will just see retinoschisis, or you will see macular hemorrhagic cyst. And these are again findings which are suggestive of abusive head trauma and strongly associated with the findings. So usually this schisis cavity will have surrounded hypopigmented or hemorrhagic arc of blood around it. There may be retinal folds associated with it, and this blood may break down over the period of time, may slowly spread, the margins may become obscure. So it's very important to look at it and photo document it when you see it, because you may not be able to document it later on. This is another patient with retinal folds and retinal schisis. You can see the cystic cavity at the level of macula, pretty predominant. There's a B scan inferiorly, and you can see the same cystic cavity superiorly. And again, this is traumatic. Most of the time, it's only ILM or NFL which is involved, but sometimes you can have macular detachment associated with it, and you can use different imaging, like they have discussed ultrasonography here for the diagnosis, including electroradiological testing. And this patient, actually, the blood has broken into the vitreous, and they have this dome-shaped vitreous hemorrhage that can obscure the fundus details. It can be seen right after the injury at the first examination. In some cases, something noticeable is you may not develop vitreous hemorrhage right away. And these patients over the period of time will subsequently accumulate blood, and that will cause the hemorrhage. This is another patient of abusive head trauma in which you can see papilledema, and that is secondary to increased intracranial pressure. These papilledema, again, may be noted at initial presentation, but sometimes the patient will have trauma, they will have corneal swelling, and subsequently will develop papilledema. But when papilledema is associated, these patients have increased risk of high mortality and morbidity associated with the injury itself. This is actually post-model image of an optic nerve sheath hemorrhage associated with abusive head trauma as well. And we covered that earlier, how optic nerve is susceptible, and that can cause hemorrhage in the sheath itself. So our primary focus was retinal findings, but besides optic nerve sheath injury, you can also have orbital floor fractures. You can have optic sheath intradural hemorrhages associated with it. You can have hemorrhage in the orbital flat. You can have them in cranial nerve sheaths, extraocular muscle hemorrhages. And something of important value here is these retinal findings are of diagnostic value. When the injury is suspected, or the abuse is suspected, or the history is inconsistent, eye findings should be placed in the context of these clinical findings. And there are several studies. This is a systemic review looking at 20 observations, essentially focusing at the eye finding itself and intraocular hemorrhages. I know it's a big range, but 44 to 100% of children with AHT had some ocular finding, compared to only 0 to 10% of patients with unintentional, accidental, non-abusive head trauma. So the sensitivity of intraocular hemorrhage in child abuse is 75% and specificity comes to 94%. Specificity is even higher if the patient has bilateral, preretinal, peripheral, moderate to severe hemorrhages. Something interesting is all unintentional head injury patients will have mild hemorrhages. So if you have moderate to severe hemorrhages, it is highly indicative of abusive head trauma. Other findings which are of diagnostic value include perimacular retinal folds and retinoschisis. Sometimes they are seen in biopsy, as we discussed earlier. These are highly specific findings. And also in an unintentional head injury or non-abusive head injuries, they can also be present, but usually when you see them, they're associated with high morbidity and mortality. Optic nerve sheath injury is described in 50% of AHT person versus 29%. So again, not as highly sensitive and less specific per se, but they still have diagnostic value. Additional injuries, as we covered earlier, should be looked into perspective of the ocular findings and should be helpful in diagnosis of these patients. Again, I'm not going to go into the details of different findings, but I do have a list of different differential diagnoses of abusive head trauma for your evaluation, and you will have access to these notes, so you should be able to see that. And as I promised, I'm not going to go into the details of all these different retinal findings that happen with AHT. But again, quick summary, these patients need to be monitored. If they have large hemorrhages, they have to be monitored closely for these hemorrhages, hopefully to spare the macula so the vision can be restored. If it's asymmetrical, you're always concerned about patients developing long-term vision loss secondary to asymmetrical vision. Also, something of importance is if you put these patients to traumatic surgery like vitrectomy, you have to do some other radiological testing, ERG for example, to look at if this patient is going to have a good prognosis from surgery itself. However, even with these implications, it's very important to do vitrectomy when required. Again, visual potential of the patients with AHT can be limited secondary to retinal or central nervous system problems. Within these limitations, when you see this patient later on in their life, as an eye care provider, be very careful to look for refractive error, treat amblyopia the way you will treat with any other patient. Try to work the best you can, maximize the visual potential so you can get the most out of these patients. Again, these patients may have other neurological, cognitive, psychological handicaps as well as visual compromise, but it's still very important to provide them care as is indicated in these situations. For those patients in which vision cannot be improved, it's good to start them early on into auditory and tactile learning processes so that can help them, and these early interventional programs are of great value in rehabilitation of these patients. Even if the child is normal, their vision is normal, still these patients should be monitored closely, at least see them back in 3 months or so to make sure they're not developing any strabismus or any other vision anomalies which is associated. So persistent problem associated with AHT includes strabismus and poor vision, again depending on the severity of the injuries. We know there are several ophthalmological findings which are associated with prognosis, and we covered some of them, are associated with mortality. For some of the factors which are prognostic in overall morbidity mortality of the patient include how their vision was on presentation, how was their pupil responding, whether there was papilledema present or not, whether they have a diffuse retinal hemorrhages or retinal folds. And again, we covered these parts, that how their visual potential depends on their CNS status. But having said that, 1/3 to half of the patients may have 20/40 or better vision. So prognosis can be really good. And most intracranial hemorrhages do resolve without sequel, and that's where their vision is really good. And if they have large vitreal or preretinal hemorrhages that require intervention, it should be placed appropriately, especially to prevent vision loss from even amblyopia. And if they develop any, they should be treated as you will treat any amblyopia for visual rehabilitation of these patients. Foveal subretinal hemorrhages are also associated with central scotoma, and these can be persistent in some cases. And I think that is, I know we kind of covered through really fast on the management part of it, and as I said, this is not something which is part of the scope of this lecture. So that was a quick summary. This is the last lecture in your pediatric retina courses. So thanks again. Again, feel free to email me if you have any questions. Take care.